So it shouldn't be surprising when I say that everybody is different. Okay, we know that when we look at someone's blue genes that they have different sizes, different colors. And when we look at the genes in their DNA, we can also see differences as well. And so when we go to Macy's or something along that line, we have this opportunity to select a number of different gene sizes that we would like. Next slide. And what's interesting is not only do we have a choice, but we could change. For example, you can see the relaxed fit, which I have graduated to as I've gotten older. And so as we think in terms of this one-size-fits-all, when we think of medicine, that's the way people try to look at this as well. And so an individual by the name of William Osler, who is the father of modern medicine, that he knew that when I took 100 people or so and treated them all the same way, that some people were treated properly and some people weren't. Some people would act differently. Some people would have some adverse reaction. And so when we think in terms of precision medicine, we try to individualize that well. We try to look at individuals' risk. We try to look at their diagnosis, their treatment, their prognosis, knowing that all these are going to be different for different people. And what I want to focus on is pharmacogenomics, where we're trying to individualize the treatment that we give to individuals. And if we look at the package insert, though, things really haven't changed that much. We find, for example, in amoxicillin, that next slide, that what we'll find is that individuals are all given the same amount, 500 milligrams every 12 hours. But we know this isn't good. Next slide. If we look at the FDA's adverse event reporting system, we notice that up to 1 million people each year now are having serious complications with the treatment that they're being given. That they're being given a drug, but bad things are happening. And we want to find a way of trying to prevent that. Next slide. And so what I want to use as an example is a drug called tacrolimus. It's used as an immunosuppressant for kidney transplantation. And if you don't get this, you're going to be at risk for graft failure or acute rejection. So what we do, if you look in this particular slide, this is a way to adjust a dose. We want people to be in the middle. This is their serum concentration. But we notice a lot of people that are high and some people are very low. Next slide. And for those people who are really high, they're at risk for bad things happening, leukopenia, anemia. Individuals with real low amounts, they're going to be at risk for acute rejection. So what we have found is there are certain genetic variants that are going to affect individuals. For example, if you have 2 loss-of-function alleles in CYP3A5, that's an enzyme that metabolizes tacrolimus, your levels go real high. And if you have wild type, you have 2 normal alleles, you're just going to be really low, and then 1 that's in the middle. Next slide. So if we overlay this information, individuals that have 2 variants, they tend to have these really high concentrations, and those with the wild type tend to be really low because their dose isn't being adjusted for what their genotype is, what their DNA says. So what do we do about this? Well, we come up with a dosing equation. We look at an individual's genetic information, and we put it into an equation. How many loss-of-function alleles do they have? We put in some other clinical information, and then using that for clearance and what target we want, we can come up with an individualized dose for that individual that's going to make sure that they have maximum efficacy and reduce bad outcomes. But this is the big problem. These are a bunch of common drugs, and the blue bar are those individuals that have a genotype where they shouldn't get that drug. And you can notice for some of these drugs, there's a lot of people who are getting drugs they shouldn't get at the dose they're being given. That's why we have all these adverse reactions that are happening. But there's another problem too. How are we going to fix this? Well, we'll sequence everybody's DNA. Sequencing the genome is pretty easy. We'll go ahead and you'll get all these variants. But there's a problem. So here's a typical individual here who will remain anonymous. And what we'll find is that this individual has 3.5 million different variants. Over 1.3 million variants in the genes. What do we do with that information? We need to take this information and put it into some sort of form that's useful for the clinician. We need, this is just 2 genes that are used for drug metabolism, CYP2D6 and CYP2C19. There's a number of variants here. We know what some of them do, but there's some of them we don't. How do we tell the clinician what to do when we have this information? Because what we want to do is we want to find out who shouldn't get the drug. It's contraindicated for that individual. Who should, the individual who's in the green, or the individual who's sort of in between. We can give them the drug, but we have to watch them. So we want to come up with this sort of a report. We want to say, for example, for Plavix, we shouldn't give them Plavix, but for Plaxtil, we can give it to them if we maybe adjust the dose a little bit. We need to be able to come up with these kind of reports. And how do we do that? Well, you create a team. And this is what we've done with the Institute of Personalized Medicine here in the College of Pharmacy. What we've done is we brought a team together of clinicians and geneticists and pharmacists to try to get to the point where we can come up with these dosing equations. We can make sure that people are given the right drug at the right dose and trying to prevent all of these things that are happening, bad things are happening, so people can be well treated. Do the same thing with risk, with prognosis, and hopefully we'll get to the point when people have disease, they'll be treated appropriately, they won't be having these adverse reactions, and that we'll be able to do the things that William Osler wanted us to do 100 years ago, where we can treat people with science instead of with art. Thanks.